Good evening, everyone. My name is Simran Chaudhary, and I welcome you all to ThinkPink Advancing Breast Cancer Treatment Through Innovation, a virtual series for Breast Cancer Awareness Month, October 2024. In this series, we explore groundbreaking advancements in breast cancer care, featuring insights from leading experts. And today we are excited to have Dr. Professor Vijay Patil with us. Dr. Patil is a consultant in medical oncology with extensive expertise in managing various cancer cases. He is an MD in radiotherapy and DM in medical oncology, making him a highly qualified expert in this field. Dr. Patil is dedicated to advancing cancer care and improving patient outcomes through innovative treatment approaches. So, welcome to our show, Dr. Patil.
Thank you.
Thank
It's
you
my
so
pleasure
much.
to be here.
Thank you so much, and it's a pleasure to have you with us today. So, since we have connected for the very important cause that is to spread awareness on the breast cancer awareness on this important month, focusing more on the treatment plans because we know people are now more nowadays more aware about what exactly is breast cancer because of all the social media, all such awareness programs like this one is going on, and how vocal is everyone about nowadays about the life going on, especially the celebrities, if I have to highlight, right? So I would be starting with some of the, if you can explain what is some of the current trends and advancements in breast cancer treatment that you find particularly promising, and how are these advancements changing the landscape of care for patients?
So, Simran, that's a good question. Understand that breast cancer is not a single disease. Breast cancer has uh, four profiles. One is it can be hormone positive, it can be HER2 new positive, it can be what we call as triple negative breast cancer, or it can be hormone plus HER2 new positive. So all breast cancers have three hormone receptors which we check for. One is ER, one is PR, and one is HER2/neu. And depending upon the different permutation or combinations of positivity and negativity, we can have these four profiles. Now the advances which are happening in the field of surgery, in field of radiation, and too many advances in the field of chemotherapy and targeted therapy which are happening. So let's take one profile and I'll give you an example. Now, for surgery, there is no need today to remove the whole breast. If it
Hmm.
is feasible, we can consider breast conservative surgery. Even if for some reasons, if we have to remove the breast, we can reconstruct the breast. So, breast is one of the sign of womanhood. So, with reconstruction of breast or keeping the breast, if the woman feels it to be that the whole nature is complete. With respect to radiation, now even that you would have seen that in old days, people used to say that, "Oh, I got a breast cancer surgery, so my there's edema of my hand." Now this we can avoid that by doing what is called a sentinel lymph node biopsy, which means we look at the first lymph node which whether in the axilla. If that is positive, then only we will do the axillary dissection. Now, if it is negative, we don't need the dissection. Now, how it benefits? In those patients on whom the axilla is positive, we do the dissection, we get them the benefit of axillary dissection. In those patients, when the axilla is negative, olden days we used to do dissection, now we don't do dissection.
Hmm.
So, the edema of the hand is not there. So, the hand is more natural, it doesn't become woody, its sensations are maintained. Now, for radiation, radiation has come a long way. From the initial, we had cobalt 60, then we had linear accelerators, now we have IGRT, IMRT, and to some extent, proton also has come. What has done is this has made the radiation treatment to the breast more easy. The breast lies over the chest wall. Below there is the heart. The if we are trying to radiate the left side, uh, on the other side, on the right side is the lung. So now when we radiate the breast, the chances that the radiation would go to the lung and the heart have also decreased. So these
Yes.
are the advances which have made in the radiation therapy. Now there are huge amount of advances which have happened in the systemic therapy, and let me give you an example. Let's look at hormone positive breast cancer, that is ERPR positive, HER2 negative. We have newer hormonal agents which have come. We have agents which can overcome the resistance pattern of the hormonal agents. Now, in ERPR positive breast cancers, today we have some genomic analysis which can tell you that you may not require chemotherapy at all, and you may
Yes.
do well with hormonal treatment itself, which is a big assurance for the patient, so that there are no side effects of chemotherapy. Uh, you don't have to come make daily hospital visits, and with tablets itself, the lady can do well. Let's go to HER2 new positive breast cancer. We now have treatments upfront which are dual HER2 blockade agents. We have agents which are what we call as ADC, antibody drug combinations, which initially, when I was getting trained in 2001, HER2 new positive breast cancer was dreaded. We used to fear for this patient the disease would come back. It would come back in the brain many times. Now with this expansion in the armamentarium of having never HER2 new targeted therapies like trastuzumab, pertuzumab, TDM1, and HER2, we are looking at cure rates of 90 plus percent in these patients. I'll give you an example. Even if you have a stage 4 disease today, and if you get HER2 new agents,
Hmm.
5 year control is beyond 70%. So you can understand how what leaps and bounds it is. Let's look at triple negative breast cancers. Now this is a situation where that many advances have not happened, but we have now have know that these many times are associated with BRCA mutations. So drugs like olaparib do well in this situation. We now know that drugs like immunotherapy are specifically useful in patients with triple negative breast cancer. So immunotherapy now we give in patients who are in curative setting in triple negative breast cancers because it helps these patients. If we come to the situation where you're hormone positive and HER2 positive, both the advances of hormone positive breast cancer and HER2 no positive breast cancers both come together. So it is just the treatment of breast cancer has increased by leaps and bounds. At one place, we have decreased the requirement of the drugs if the patient is not benefiting. And at other place, we have increased the requirement of the drug depending upon how much the patient benefits. And definitely targeted therapies and immunotherapies have changed the way we treat breast cancer today.
And I think that is all because of the advancements, how the research industry, the medical industry is growing up, right? And this innovation is actually helping us and acting as kind of, what do we call this in Hindi, a vardhan, right? For the patients, for to fight out, to combat the diseases. So I think that's better for all, for the medical industry and for the patients as well. So thank you so much for explaining this so well to us and to all our audience. Moving on to the role of personalized medicine. So personalized medicine has become a significant focus in oncology. Like we were also talking about the targeted therapies, right? So how do you see the role of personalized treatment plans evolving in breast cancer care? And what factors are considered when tailoring these plans for patients?
Okay, so today personalized treatment needs to be planned for every breast cancer patients.
Hmm.
So I'll give you to stress upon this. I'll give you three situations and I'll tell you three of my own patients' experiences. So let's call the first patient X. She's a 70-year-old lady who, in a routine checkup, finds that she has a breast lump. So she gets operated. It is
Hmm.
a small lump of 2 centimeters, and now she comes to me to say, "Ki doc, we have got operated, and we have got sentinel lymph node dissection. It's a T2N0, which means only it's actually a T1, which means a small tumor, no nodes, no distance spread. Now she has to go to Dubai to attend her daughter's wedding and wants to stay there for a bit of time, and she's concerned about chemotherapy. So the first thing we would say is, okay, let's look at the ERPI on HER2/neu and the Ki-67. What we see
Yes.
is that the ERPR was positive, HER2/neu was negative. Now this is a candidate who may not require chemotherapy. She can do well with tablets itself. So in this patient, we order a test called Oncotype DX or a mamma print, which is a 21 gene, or mamma print is a 70 gene signature predictive score, which gives a prediction score. If the score is high, which means that the patient has high chances of the disease coming back, so you give chemotherapy. If the score is low, then the chances of the disease coming back is low, so you don't need to give chemotherapy. For oncotype DX, which is recommended by the US government, the score is actually 26. So anything above 26, you give the treatment, and below 26, you don't require. Now the score of this lady came as 12, which means she did not require. Only she
Hmm.
required it was one pill of hormonal agents, and we started it her, and she happily could do all her work, and she's
Yeah.
doing well for last 3 to 4 years up till now. Now, what this tells you is that using personalized medicine, we did not have to give chemotherapy, which was going to be there for 4 months or 5 months, which would
Yes.
have required n number of hospital visits, which would have given her 30 to 40% side effects, and it would have already also drained her uh, financially. So no mental, no physical, no financial stress because we did not have to do chemotherapy. So what here is the situation because of genomics we know that less is more, which means we did not have to the lesser the treatment, it was more the better for her because quality of life was better. So that's example A where newer personalized medicine can actually cut your. I'll give an example B. When a lady comes to me around 2 years back, she had an old history of breast cancer, and she came with an altered sensory. I check her and I find that she has again a lump in the breast. We do the test and we see that it is breast cancer. And she has history of multiple cancers in the family. So we do a genomic test to see which type of mutation she has, and we get a common mutation called BRCA mutation. Now, unfortunately, the disease has also gone to the brain, and that's the reason. Now,
Okay.
the husband is really worried because he's a well-read person and he has gone on Google and he has taken help of the Google doctor who has told him that such patients don't do well and many of them may not be that after 6 months, and he was really worried. Now, within this, we got this genomic, we just started him on one tablet. She started walking. She does all her activities. She is now arranging the marriage of her daughter. So if we won't have done the genomic testing, let me tell you, the prognosis of this patient was very bad. So it's important that you personalize the treatment for this patient. Next case, I'll tell you. A lady comes who has uh, gone for a picnic and she has a fall, and now we come to know that she has disease in the bone, disease in the lungs, disease in the brain, and there's a mass in the breast cancer also. So this is breast cancer stage 4, which is spread to all parts. We do a biopsy, it comes out to be HER2 positive.
Okay.
Now, because she was HER2 positive, we started her on what was called as a regimen called docetaxel, pertuzumab, and trastuzumab. Every tumor is disappeared. She's in the complete remission, and she's continuing it. Now, this is the way I'll tell you the way whether to escalate, whether to not to escalate, whether to de-escalate, what to give. You can actually curtail. You can. What I would say is, uh, one way is we buy shirts going in the showrooms on and in shops which are like XL, double XL. Other is we go and stitch it.
Mm.
Now, personalized treatment is like stitching your own clothes for yourself. They fit the best, they give you the best comfort, but they have to be stitched well with all the information.
Tailor-made medicine.
So
Yeah.
yes, tailor-made is always better. So personalized medicine, and what I mean by personalized is not only doing genomics.
Hmm.
Many times it also takes care of what are the wills and fancies of the patient. So there would be patients who would come and tell me, okay, doc, I may not want this therapy for so long. So what are the options you have? Understand that guidelines also give you 3 or 4 options. It is important to ask for all the options. And then depending upon the option which suits you, you take the options which will be required.
I think you have explained this with so many of good examples. Now we all understand how personalized medicine works and why in the coming times it is important because like you also mentioned, there's not too many things. Less is good. So there's nothing key. We are giving this, that, and all kind of therapies together, and then trying to fix this out. Just one thing which actually will target to the point, will address the issue, and I think that's enough. That's
Correct.
how that's how the advancements are helping us. That's how the new the scope of targeting and treating cancer is looking to us, because like we always said in every session like these or panel discussion, that cancer was is no more a deadly disease
Correct.
because of the new treatment plans we have. And to thanks to all the doctors and the researchers who are working behind this tirelessly for making out, trying new ways out and every other thing possible. So moving on to the importance of early detection, because you also mentioned one case. You mentioned a lady who every time's come for her regular checkup and then diagnosed with a lump on her in her breast. So it got diagnosed early or easily because maybe she used to come for regular checkups, like you mentioned. So early detection is crucial in breast cancer outcomes. So in your experience, what are some of the most effective strategies for early detection and diagnosis that you recommend to patients and healthcare providers?
Every lady above the age of 40, once in a year, needs to do a health checkup.
Hmm.
And that's not only for cancer, that's for physical well being. Many times I get patients who say that I have never been to doctor. That's not something to be proud of. That's actually something to be ashamed of. See, we don't go to hospitals only when we are sick. We go to hospitals to maintain health also, which means a health checkup every year is required.
Hmm.
And it's an unfortunate thing, and this is very commonly I say even in medical conferences that though there would be at least 50% female doctors who are sitting there. How many of whom have got themselves screened for breast cancer? And I'll tell you the rate is not about 10-15%. Somehow, as a society, we think that things bad can happen to a population, but they won't happen to me. Understand, we are a part of the population itself. So we need to address this issue. We need to educate ourselves and we need to take that step forward ourselves, that we'll go and get ourselves screened. And screening is the only way. When you are asymptomatic, it's going to detect early. If you are symptomatic, like you have a lump in the breast, or if you have seen that the nipple has got inverted, or if you have seen that the skin over the breast has become red, then it's already too late. So when you don't have any symptoms, when you don't have any problems, that is the time you're supposed to go to get yourself screened. And not only for breast cancer. You need to females need to get screened for both breast and cervical cancers. Both can
This
be detected early and both can be cured when they're detected early. The cure rates in early situation are nearly 100%.
cure is
And
in
even
our hand only.
required is
Yeah, yeah. I believe cure is in our hand only. The regular checkups we do early, it get detected, and early the treatment plans can be started. And I think there's no other challenge because the treatment gets started early. So yes, awareness and education is most important for every person out there. And we are just talking about this education and awareness thing for the patients. So like we say, how important is patient education and support in the treatment journey for breast cancer patients? Because we know when doctor break this news that a person or the patient is diagnosed with this breast cancer, it is very difficult to accept for the patient to accept this news. And doctor has to give the confidence to the patient, okay, this is a plan, this is a treatment journey, this is what we are going to do. So how it is important and what initiatives are taken in your hospital to support patients and their families for this kind of situations?
so. See, first of all, Hinduja Hospital has regular health checkups plans which are there. Okay, and which take care of not only of cancer but non-cancer things also. Second is we do not decline treatment to any patient depending upon what their finances are. We are
Hmm.
very proud that we have a public relation department. If any patient cannot afford, we still give the latest therapy and the public relation department pitches it. The program of Hinduja Hospital, according to me, is one of the best in the country to do the to have adequate treatment delivered to the breast cancer patients. And we do not believe in delivery of just chemo, targeted therapy, immunotherapy, surgery, radiation. Understand? Apart from this, a lot of ancillary care is required for the patient. Psychological support, dietitian support, uh, uh, wigs, breast bra support, and all these options are given to the patient. Understand that treatment is one part. You need the so for example, when you see a cricket team, you don't require only the coach. You require the physio, you require the trainer, you require the mental preparation. Now we are moving towards that in cricket, which we never used to see this 15 years back. These
Yes.
things are also required with the cancer patients. So it's a complete team effort. It's not an effort of one doctor or a one person.
You said it right. It requires a complete team and it's a team effort. So, being a doctor, dealing with all these kind of things every day, you always you may come across a few of the challenges while treating breast cancer. So, what challenges do you encounter in treating breast cancer, particularly with regard to access to care, patient compliance, or emerging treatment modalities, and how can
So
these
I
challenges be
yeah.
addressed?
So I'll take it one by one. So
Hmm.
when first talk about patient compliance, which is the easiest thing to do. So you would be surprised, Simran, that the data suggests that when we give hormonal tablets to the patient for 5 years or 10 years, 34% of the patients don't take it.
Hmm.
Perfect compliance is achieved only in 50% of the patients. So these are simple pills which we just need to take on time. If you don't take that on time, then things would go wrong. So first is compliance is important. Second is we need to have treatments which are accessible to our patients. Now, with the help of generics, many of the treatments have become accessible in our country. And with more and more generics coming, I think targeted therapy is going to become more and more accessible in our country. I'll give you an example. When I was a part of Tata Memorial Hospital, I did a large analysis of around 14,000 patients to see what is the excess of neoimmunotherapies. It was only 2.8%. There's a similar paper by one of my colleagues called Dr. Jaya Ghosh, where we saw that the Herceptin before in 2010, the accessibility was only 10 to 15%. Now, there are multiple reasons for this. One is the cost of the drugs. So most of these drugs come from outside India, so they're costly. So once the generic kicks in, the cost of this many other drugs comes below and accessibility increases. Second is a lot of associations have like WCI funding, women and child funding have come up, which take the mantle on their own to provide funding for these patients. Now, still, it is not 100%, but with the generics, many of these costs have come down so much that in government scheme like Ayushman Bharat also, you can give very, very good treatment for these patients.
Yes. But I believe government and the private sector partnership is working on this, and that's how we are overcome.
Similar, it is always going to be required. So
Yeah.
normally, whenever we talk about cancer, we talk about Tata Memorial Hospital. See,
Yes.
around 14 lakhs patients get diagnosed with cancer every year. Tata
Hmm.
Memorial Hospital registers around 30 to 40,000 cases, which means they don't even register 1% of the cancers of this country. And these are only things which get registered. According to statistics, our numbers are 2.5 to 3 times more than because many patients don't get registered at all, which
And
means
many
that,
not yet diagnosed also.
yeah, they will not even get diagnosed. So in villages, you don't have registries. You extrapolate it as. So, for example, when you look at Maharashtra as a whole, we have one or two registries only. We don't have
Hmm.
registries for hospitals. We don't have registries at small nursing homes. We don't have registries at rural hospitals. So many of the cancer patients do take treatment. Surgeries do happen. We don't have that data at all with us. So what this tells you is key government setups can treat only up till 10 to 20% of the patients. It's the private sector which treats 60 to 70% of the patients. More so in metros, where this is nearly 10 to 90%. So when I was in Tata, we used to get very few patients from Mumbai itself.
Yeah.
Most of the patients get treated at the private settings. So what does that mean? That unless you have a strong private government partnership, private hospitals doing as good as the jobs as academic centers, your progress is not going to happen and patients are not going to get good treatment.
Yes, you said it right, and I think That's how a government and private hospital can work hand in hand and work this out. Private hospitals or private sector has this capacity to treat more patients, and government can act as a regulatory body, which actually it is working as, right? But
So,
they are also putting some, yeah.
Simran, I won't agree with that. See, it's a partnership. It's a partnership between two equals. No one
Hmm.
has to regulate anyone. Okay,
Hmm.
if you need to do regulations, you need to see that the protocols are discussed in tumor boards, where your colleagues also see your doses, the colleagues also see the plan, and these protocols need to adhere to the international guidelines. It does not happen that in government hospitals all the time guidelines are followed. It does not happen in private hospitals that all the times of guidelines are. You will require patients in which you will have to tailor the guidelines. So it's important that if you are treating the patients and if you are not following the guidelines for any reason, be it accessibility, be it comorbidities, be it logistic challenges, then you discuss in a tumor board. Take all
Hmm.
your colleagues on board so that it's we know that what were the reasons why this guideline was not followed, and that gets documented, and
I
that's where
think
the
that
data gets generated, which helps in future planning.
that's the way out, because it actually has to address all those problems those people are facing every day. Like, doctors treat all these things. What are the problems they are facing? How can that be resolved? What regulatory regulations can be made on that? So I think this require a cumulative decision on this. A body has to sit, discuss, decide, and then it actually has to address their everyday problem.
So what you're saying is correct, Simran. So I have a habit, and that's the reason we got late. I have a habit whenever I'm discussing the protocol with the patients to show them international guidelines, to show
Hmm.
them why we are selecting this regimen. What was the evidence for this selection? What are the side effects, and how the flow is going to look? So what then that confidence comes into the patient that okay, I am being treated exactly the way I would have got treated in US or Europe somewhere.
Yeah.
Not only that, if we are changing, why we are changing? Why is the logic behind changing the therapy? Gone are those days in which you would just write out the prescription that this is you need to do and do that. I think the patients require much more diligent handling than that, and it needs to be a shared decision making between the patient and the doctor, where you are aware why these decisions have been taken. The second thing is we need to regulate our insurances better. Many times I see patients who are struggling with their insurance. They have an insurance number, but they don't know what to do with the insurance. Two or three reforms are very required. And I'll give you a practical example which I faced with one of my patients who told me, Sir, I did the insurance 20 years back. That time, 15 lakh was a very big amount, so I did it for 15 lakhs. Today, I find that 15 lakhs is a very small amount. And this is exactly what I tell my colleagues. See, don't do the insurance for today, saying that you are going to do it for today. Do the insurance after 20 years because let's say your age is 30, 40. You're going to require this after 20, 25 years. Do the insurance at that stage or plan for that stage of your life. And I think there needs to be some inflation adjusting, which the insurance companies also need to do. I find them very easy for not, and you would find on social media many posts by me where I would criticize the insurance. They're saying that okay, this we won't give, this we won't give, saying that this is newer form of therapies. See, no
Yeah.
one knows. I don't know after 20 years what newer forms of therapies I may require. I am paying for the insurance so that I get treated with the best possible treatment after 20 years. Just because it was not written in small letters
Yeah.
in my form today, and no one can predict that what would be treatment, declining that, I think is a big breach of trust. So we need insurance reforms dearly in this country where we inflation adjust the insurance. We see that the therapies which are required are incorporated just because in small print they were not there when the forms were printed. That does not decline, and we need a better smooth way of delivering this to the patients. I think they deserve it if someone has been paying their hard earned money for 20 years, 30 years, thinking that this is going to help me out when I'm in trouble.
Yes, you pointed out a very right point. This process has to be smoothened enough so that if person is going in a pain or any kind of he's in a trouble and have had paid such amount regularly, and there's no benefit if he has to go this to and fro, and so much of hustle is there, then it feels like whatever we have done for the past 20 years, is paying me no none, is giving me nothing now.
Correct.
It's adding more tension to it.
Correct. And
Yeah.
and the bitter part is you paid for that insurance thinking that when you would have rainy days, it would act as an umbrella, and then you think that umbrella doesn't open in time when the rain actually is there.
You said it right, and I believe there's so many loopholes which needs to be addressed, which needs to be solved out, and this can come out through such open discussions, such forums where doctors, patients, government policy makers, everyone can sit together and openly discuss, and that can be challenged or can be solved. So I
That's a
think.
big challenge, Simran. Normally, when we have government conferences going on, doctors are not invited. When we
Hmm.
have our advanced conferences going on, government employees don't attend or we don't invite them. So this dialogue doesn't happen. We are also at fault. We are in our old universe where we want to discuss what are the new advances, what is but access as a discussion doesn't come up in a country where access is actually an issue.
You pointed out very rightly, but someone has to bring this, and let's hope that this happens very soon. But moving on to my last question of this session, as we observe Breast Cancer Awareness Month, so what message would you like to convey to patients, families, and the general public regarding the importance of awareness, early detection, and advancements in treatment?
Only one message. Every person above the age of 40 needs to do a regular health checkup once in a year, in which you get screened for the common cancers which happen in the country. If you do that, things will get sorted.
I think this was very loud and clear to everyone, every listeners out there. So thank you so much, Dr. Patil, for coming to our platform, becoming one of our strong voices to raise the awareness on breast cancer, to educate our public, to raise awareness on this important issue. And thank you so much for sharing all your insights and expertise. It has been a great session for all of us to understand this more deeply. Thanks a lot.
Thank you, Simran. Bye. Take care.
Bye.